The MajesTEC-1 trial, which was the pivotal trial for getting Teclistamab approved to treat multiply relapsed refractory myeloma, is the trial that keeps on giving. And so there are many different cohorts of patients that are still being explored in the MajesTEC-1 trial, looking at various ways, for example, to administer Teclistamab. And one of these is there are two cohorts where we explored alternate step-up dosing. Now, why do we do that? So the standard step-up dosing, of course, is the 0.03, 0.6, 1.5. That's the standard mg per kilogram step-up dosing that we use for Teclistamab. And with that, the CRS rates we know from the MajesTEC-1 pivotal trial occurred in roughly 3/4 of patients, mostly grade 1, a little grade 2, and most of it occurred during the step-up dosing, but not all of it. There were patients who experienced CRS events outside the step-up dosing period. Now, why is this important? Well, I think with Teclistamab, there's been hesitancy for widespread adoption of giving bispecifics, especially amongst our community hematology-oncology colleagues. And the hesitancy largely, I think, is focused on management and incidence of cytokine release syndrome, or CRS. So in this trial, the goal of the trial was to explore two different step-up doses, where only two step-up doses were given at higher doses. One was 0.1 and 0.5, and 0.1 and 0.5 mg per kilo. That was 0.2 and 0.7 mg per kilogram, given just two step-up doses. And the hypothesis was, well, will this make the CRS events more predictable, and would it confine them to the step-up dosing period, and therefore not make doctors and patients anxious about the possibility of experiencing CRS after the step-up dosing period? And so that's how the study was done. Roughly a dozen patients in each cohort. The dosing was, after the step-up dosing, is 1.5 mg per kilogram every 4 weeks after the step-up dosing. So different than the label, it became every 4-week dosing. And sort of on the flip side, efficacy wasn't assessed in the trial. It was mostly looking at CRS and other side effects. Hypogammaglobulinemia was about the same. Infections were no more common. And so ICANS was low incidence, as seen before, not a big issue. What about CRS? So CRS again occurred in the usual roughly 2/3 to 3/4 of patients, all grade 1, grade 2, and it all occurred during the period of the step-up dosing. None of it occurred after the step-up dosing was done. And the management of CRS is what you would expect. Roughly 50 to 63% of the patients received tocilizumab to manage CRS. Very few patients required additional doses of tocilizumab, and then they were managed with steroids, antipyretics, the usual thing. And so what's important about the study? And what's important about the study, I think, is that it raises the possibility that if we were to employ alternate step-up dosing at higher doses, would that make physicians more comfortable giving Teclistamab in their practices, knowing when the CRS was more likely to occur, not worrying about it after patients were outpatient and being watched in the clinic. And I think that's one of the provocative aspects of the study, I think, and it remains to be seen what we do with this information.